Amazing talks by both of these outstanding presenters. Thank you so much. So great. I'd like to invite you both back in, and we have about 15 minutes for questions and answers and discussion, and really set up a lot of really exciting questions. So I thought maybe I would start with a couple questions to each of you that really raise some of the ethical and societal issues that we've really been discussing for the last 2 days. So maybe starting with Dr. Katabi, the Emerald device is absolutely fascinating, with true possibilities for non-invasive sensing across all sorts of things, including some of the substance use disorder questions that were just discussed. However, and the ability for using all of these are amazing, but what are the risks? Are there, there seems to be a little bit of a component of big brother worries here. One of the questions on chat was, how do you ensure these devices, the privacy and security of patients? So what are your thoughts about how do we optimize the advantages and minimize the risks?
Yeah, thank you very much for the question, because this is very important. So there are two ways that we address security and privacy. One is technological, and the other one is in terms of policy and what we do actually in our studies. So in terms of technology, we don't have in our system any PHIs, any PIIs. It's completely separate. Of course, everything is encrypted, but it's just like all of the information that is related to PII is completely kept separately. And in fact, we try not to keep it. We try to keep it with the site and say this is completely separate and coded information in all of the time. So that's one thing. The other thing that is important is, of course, that the system also is organized such that you can, so our policy is that the patient owns the data. So it is up to the person to decide who to share that data with. And not just that, actually, the person can say, for example, I think I would benefit from monitoring my sleep, but I don't want you to monitor my movements. Right? So that you don't have to like all or nothing. It's just like based on the disease, based on the condition, based on what is needed, you can just opt in or opt out to individual monitoring aspects. And of course, everything that we do is under IRB and proper protocol and informed consent.
Great, thanks. It'll be interesting, as I think will be an ongoing discussion for all of these technologies, what do ethics look like. Dr. Volkow, yesterday's morning on a fascinating panel about the very hot yet controversial field of psychedelic approaches to psychiatric disorders, ketamine, psilocybin, MDMA, among others, combined with digital augmentation to enhance plasticity and mood. There's a lot of excitement about this, but of course a lot of controversy. And we're curious about your thoughts or NIH's position on this area. One of our Slack channel comments was, another side of this is that psychedelics and cannabis have been legalized in Canada, and that those might be great learning examples in the healthcare space for safer legalization and acceptance. And the final part of this is, do substance use disorders present any special ethical concerns when it comes to using digital phenotyping-like approach beyond those of other psychiatric disorders? So broadly, what do you think about the ethics of psychedelics in treatment, as well as broadly about, do substance use disorders need to be considered differently when we're thinking about technology? Thank you.
Well, I mean, my question is for both. Well, for the first one, yes, we should actually do science and research and take advantage of what nature has given us, which is the complexity of chemical substances and the diversity of proteins. So, I mean, I think that the example of ketamine, which is a drug that can be quite addictive, and people in Africa, in some of the countries, is the main drug of abuse. And yet it can be utilized effectively to help people with depression, and you also can deliver it in ways that minimize its diversion. So yes, we can address the issue of the possibility that there are drugs that, and again, in the case of psychedelics, it's actually not even traditionally like with stimulant drugs that increase dopamine or even opioids that are very pleasurable. Psychedelics are misused because it creates an alteration of your experience. So in that respect, they don't produce the same pattern of compulsive taking that you see with something like cocaine. But the concern obviously has to do in psychiatry, and we've been aware, is that the improper utilization of these drugs can result in severe mental illness and can make people very, very psychotic. And people in one of those psychotic episodes, for example, can end up doing a violent action, or they can end up killing themselves. So again, that does not negate the capacity that we have to take these substances and identify very specific conditions and for whom they may be valuable. And so I do think in terms of the opportunity that we have of exploring how can, if they can promote synaptogenesis, for example, and you can generate neuroplasticity and you can link them acutely with an intervention and you can accelerate the behavioral positivity, why not? And I think that's, but again, recognizing that at the same time, we have to be very, very cognizant and conscious about how we express this and not generate this whole notion of, because we're using medically, they are safe for anyone to use. And I think this is part of the pattern that we're seeing with cannabis. And I think that there is evidence that yes, THC and CBD, ingredients of cannabis, can be utilized for analgesia. There's evidence like that. But then when you take it and say, okay, widespread, you can automatically rely on the use of marijuana for the management of pain. The evidence needs to be built up so that you can learn how to use it with minimal negative effects. And there just came a paper on ACNP journal, actually recently, that shows that when you combine marijuana THC with oxycodone, you do enhance the analgesic effects of oxycodone, just so you need a lower dose. But you also increase the drug liking of oxycodone, so you make it more rewarding. And again, understanding, I mean, we do science because we need to have knowledge and use that knowledge in terms of guiding intervention. So I'm very much interested on this whole concept. I think it is a valid question. I brought it up the other day to my own staff and I says, guys, maybe we should consider as a harm reduction the possibility that there are certain drugs that can help patients. And this came up with respect to kratom, which is also apparently more or less widely used in the United States by people for pain or for addressing opioid use disorders and even for depression. So if we close our eyes to data, then we shouldn't be doing science, and then we lose all of our value in the scientific community and certainly as an agency that funds research. So that's one. And the second one, which relates to should we be dealing with substance use disorder differently than other conditions? My answer to that is we shouldn't. I think that this is what has led to the stigmatization and the difficulties that we constantly encounter with substance use disorder. I was shocked when I looked at, I was evaluating, again, in these large electronic health records, the prevalence of medical comorbidities for different substance use disorder. I was shocked about how high they were, because this is not I mean, clinicians don't think about it. They don't ask their patients that are coming there for hypertension, are you taking drugs? Or a patient that is starting to develop dementia, I mean, how much are you drinking? This, if we don't ask, we will not know. And I think that to the extent that we have generated this gap, oh, it's a substance use disorder, we ourselves are continuing to contribute to stigmatizing it. I think that the question that you asked before is whether it's an individual with substance use disorder, mental illness, or any other medical conditions, we need to consider the certainty that we are respecting their privacy, that we're doing our interventions in a way that is safe for them and that improves their outcomes. But I would not continue to systematically treat substance use disorders differently from other medical conditions.
Well, thanks so much for your thoughtfulness and leadership. Great answers. Dr. Katabi, we have several specific questions. I'm going to ask a general one and then maybe hopefully have enough time for a few of the very specific questions that are coming up as well. One of them is can the technology, a lot of what you show is how really we can use this technology for research, but is your vision that it would eventually be used for sort of real-time active biofeedback in one way, shape, or form to the patient? And then what are your thoughts about some of how that could be used for behavioral, disorders in which active behavior can be, minimized? You've looked at whether we've talked about seizures or respiration or other kinds of active behaviors in a way.
Yeah. So the way I understand your question, actually, there are two aspects. One is between research and actually being used in healthcare and in drug development and so on. And the other one is real-time versus non-real time. So let me take the first one. So as I mentioned, alluded at in the talk, over the last 2 years, actually, we moved the technology from the lab to the homes. And now our devices are in the homes of hundreds. I mean, I would say like maybe over the time, like more than 400, 500 people in their homes. Like we have currently, like we have devices with Parkinson patients for over a year now, and it's showing up so many interesting things in Parkinson, and also that it's really how it relates to every aspect, from the tremors and the motion to the sleep to to even the respiration, like we are talking about. And then, and also we have it with other diseases like autoimmune diseases like Crohn's, for example. So going to the home and being actually used by actual people, patient, individual control in real life to address diseases, various diseases that we have done. And it is now being used. The other thing is the real time. And I think the point is how real time you want it to be. So one thing I think, so we haven't made it, much of what we have done, we haven't made it very real time, like we operate on batches because we do observational. So I think the next thing is the real time that you are talking about. And I think there are certain things, there are different things of real time. So one thing is that if somebody is like overdose themselves and you want really like seconds or even split second that information as much as possible. And then there is the other thing, which is understanding medication response in diseases like mood disorders and in psychiatry. It takes time, and just the actual physiological change takes time. So you are talking about real time, but you are talking on the orders of days, weeks, and so on. I think that is a very interesting next step for us, and we are working on it, and we'll take it step by step.
Great, really, really exciting promise. Dr. Volkow, a lot of those kinds of technologies that we just spoke about, whether you're watching overdose or someone brought up potentially seizures that can be increased in the aftermath of cocaine use, are really about what does the patient do, almost an operant behavior process. And yet so much of treatments that's really successful in substance abuse comes through motivational enhancement. There are many ways that technology can be used in these passive ways, but that they might require to be motivated. Can you imagine ways, or do you know of people working on ways that technology could be used to enhance motivation for the treatment as well?
Absolutely, and I think that we are all basically subject ourselves in terms of the reinforcements that go that motivate in our actions. And I think that the Fitbit has been a major success that way. Just to see the little number of steps that they're doing actually drives us to do more and more and more, and we can get compulsive into it. So you can use that to engage. That's the challenge. And of course, in substance use, we value contingency management, and contingency management can have many phases, as you realize that. But one of the most common them is give them prizes or give them money. But there may be, again, the opportunity of having alternative contingency managements that may be more reinforcing, like they are doing right now in experiments with rodents, where the contingency management is the opportunity for an animal to press a lever so that they can play with someone else. I think that there is, how do we enhance motivation? How do we make it much more salient? I think that is something that we can manipulate. And I've been very intrigued about it, because I think in terms, for example, there are opportunities in other areas of psychiatric disorders, like in ADHD. If you can make something more salient, you're going to enhance attention. You're much more likely to sustain energy. And when you're dealing with addiction, you have two components. One of them is to drive them to engage in something other than drug taking, but you also want to enhance the motivation and energy to ability to restrain for doing something you want very much. So you have two elements that by using technologies, you can actually, in principle, at least theoretically, target. And I think that we can target. We're doing it with money, because money is such a universal reinforcer. But I think that we can be much more sophisticated in the future than that.
Thank you. Just one follow-up on that that's somewhat related. Many of the speakers have talked about the importance of maintaining client engagement. within the role of families that may play in addition to clinicians in facilitating digital health adoption. Any thoughts about specific aspects of that in substance abuse or broadly mental health?
Yeah, no, and I think that, I mean, it's a very good question, because ultimately when in addressing the whole issue of treatment and prevention, I sort of says the most powerful tool that we have literally is each other. I mean, we are social creatures, and to the extent that we have access to people that with whom we have meaningful connections, that can be positive in helping you achieve recovery or preventing you from taking drugs. To the extent that those individuals that can be the strongest allies that we have, stigmatize, discriminate, isolate, we're making those people so much more vulnerable. So using technologies that can facilitate strengthening ties for individuals that may be not lucky enough to have a family of support can provide alternatives. And in the COVID pandemic, access to some of these groups has been very, very valuable. And we probably can very much improve in ways that they may actually feel even closer. So we're just exploring it in a relatively short period of time, but I do think that it has tremendous, tremendous potential.
Wonderful.
I enjoy seeing faces now on the screens. I sort of see my nucleus accumbens gets activated. Which
right,
it didn't.
That's great. We're down to our last couple of minutes. So I'm going to do some rapid fire questions for Dr. Katabi. There's a lot of interesting questions about the technology. If you have more than one individual in the room, how do you know who's who? Have you compared this with sleep polysomnography? And if so, how do you deal with the other electromagnetic waves? And more broadly, if you have microwaves or TVs or other EM producers, how does that work with the system?
Okay, so the technology monitors multiple people, and so we do that. And of course, most homes have multiple people. In fact, we can get the sleep of two individuals, even if there are two individuals in the same bed. So that's one thing. The other thing is about also the sleep in comparison to PSG. We compared with PSG in the sleep lab, and the results are very similar. It's also 80% in comparison. And again, PSG is evaluated on a 30-second epoch. That's what I was referring to.
Wonderful. So for our last brief question for each of you, what are you most excited about related to your technology or your field in the next 5 years, Dr. Volkow?
Well, I'm most excited. I mean, I'm incredibly excited about how the whole technology has changed the way that we do things. And to me, perhaps, if you ask me what is it that I think may have the greatest consequences in terms of, I've been very, like, I'm sure a lot of people be very concerned about the health inequalities and the social disparities that we're observing. And it's relevant across many medical illnesses, but in substance use disorders, it's crucial. And it's something that starts to affect someone since childhood. And one of the main drivers has to do with limited access to education. And through now technologies, in principle, theoretically, we should be able to provide high quality education to every single child. And I think that's probably one of the most powerful investments. And you say, what am I speaking about education? In terms of prevention, the risk for substance use disorder, the most consequential.
Thank you so much. Dr. Katabi,
Yeah.
what are you most excited about in the next 5 years?
So actually, I'm just going to mention one thing that I'm very excited about, and actually Nora hinted at it, and I don't know whether she has a similar, like basically, from our experience, breathing is very underused. I mean, not only, I didn't show this result, but also we saw, for example, we were monitoring people who were taking oxycodone because of surgery and stuff like this. And we see the breathing depression when they overdose on the oxycodone that they were given. But I think it's more than that. So for example, in the study that we were doing with COVID, I mean, this was in assisted living. People have some cognitive and some psychological problems. And you see when they change their drugs, and these are just like drugs that affect like basically their mood and their anxiety and agitation, their breathing changes. And you start seeing even like more complex behavior, like they have low respiration rate with high respiration rate and alternating depending on the sleep stages. So it's, I think there is so much to learn about the brain by actually the peripheral signals. And I think respiration in particular, because it is really in a part of the brain that it interacts so much with so many aspects. It just can open up so many things, and it's worth studying in the future.
Outstanding.
I agree.
And as an anxiety researcher, panic and all the things that you can get from respiration there too. So thank you. We're already a minute over time. Thank you, Dr. Volkow and Katabi, for just an amazing set of presentations and really fun and interesting discussions. Hope everybody will continue the discussion in the Slack channel. And I'll hand it back to Dr. Sava to introduce our break. Thanks again.
Thanks for having me.